Seat the patient and be sure the patient's clothing is protected with a napkin. Please select the stock tray that will cover all the landmarks indicating the denture-bearing areas. Check the impression tray and make sure it covers the hamular notches posteriorly. Deficient tray borders should be corrected by adding utility wax. Mix the alginate following the manufacturer instruction. Then load it into the stock tray. Stand in front of the patient and place the tray at the left corner of the mouth. Reflect the right corner of the mouth with a mouth mirror. Seat the loaded tray posteriorly first, then push slowly to the front so that the alginate flows anteriorly. Center the tray over the residual ridge so that the tray handle is in alignment with the median line of the face. At this time, elevate the upper lip so that the alginate flows into the labial sulcus. The seating pressure is stopped and border molding is performed so that the impression is not overextended. Hold the tray in place until the alginate has completely set. Remove the impression from the mouth. Inspect the impression to determine if it is acceptable. Disinfect the impression using current recommended surface disinfectant for 10 minutes in a sealed bag prior to proceeding to the lab. Alginate impressions tend to be overextended, so the denture outline should be drawn on the impression with an indelible sticks. This outline will be transferred into the cast and will be helpful to fabricate the custom tray. Select stock tray that will cover all landmarks indicating the denture-bearing areas. Also check the impression tray and make sure it covers the retromolar pad, external oblique ridge, and mylohyoid ridge. Any deficient area should be corrected by utility wax. The wax should be used on the posterior, lingual borders, and retromolar pad to carry the alginate into the lingual sulcus. The alginate is mixed following the manufacturer instruction. Then loaded into the stock tray. Stand in front of the patient and place the tray at the left corner of the mouth. The right corner of the mouth is reflected with a mouth mirror. Center the tray over the residual ridge so that the tray handle is in alignment with the median line of the face. At this time, the lip is pulled out so the alginate flows into the labial sulcus. The seating pressure is stopped, the border molding is performed so that the impression is not overextended. The tray is held in place until the alginate has completely set. Remove the impression from the mouth. Inspect the impression to determine if it's acceptable. Disinfect the impression using current recommended surface disinfectant for 10 minutes in a sealed bag prior to proceeding to the lab. Alginate impressions tend to be overextended, so the denture outline should be drawn on the impression with an indelible stick. This outline will be transferred into the cast and will be helpful to fabricate the custom tray. Mark the outline of the tray starting at the pterygomaxillary notch. Make a red line 2 mm to the depth of the vestibule, or the blue line. Note that the tray will be made short to the vestibule by 2 mm. Continue the line to the opposite side. Block out excessive undercuts in the preliminary cast with base plate wax. Do not over wax the cast or the tray will not fit the mouth accurately. Be especially conservative with your wax blockout in the maxillary labial flange area. Too much wax blockout can cause just as many problems as too little blockout. Apply a light coat of Vaseline over the entire tissue surface of the cast to serve as a separating medium. Place a sheet of custom tray triad resin in the palate of the cast and adapt the resin gently, moving from the depth of the palate to the borders of the vestibule to avoid trapping air bubbles under the tray material. Carefully trim the material to the red line previously marked. Make the borders of the tray as smooth as possible prior to curing the resin, as it's much easier to smooth it when soft. Take care not to use excessive finger pressure and thin out the resin. Cure the material for 2 minutes in the triad unit. Remove the tray from the cast, invert the tray, and complete curing for 6 minutes. Mark the outline of the tray. Make a red line 2 mm to the depth of the vestibule or to the blue line. Note that the tray will be made short to the vestibule by 2 mm. Continue the line to the opposite side. Block out excessive undercuts in the preliminary cast with base plate wax. Do not over wax the cast or the tray will not fit the mouth accurately. Cut a V-shaped wedge out of the middle of the triad sheet to allow adaptation of the material to the lingual part of the cast. Carefully trim the material to the line previously marked. Make the borders of the tray as smooth as possible prior to curing the resin, as it's much easier to smooth it when soft. Take care not to use excessive finger pressure and thin out the resin. Cure the material for 2 minutes in the triad unit. Remove the tray from the cast, invert the tray, and complete curing for 6 minutes. Check the custom tray in the patient mouth and adjust any overextended areas. Soften one end of the green stick compound slowly over alcohol torch. Place the compound along the anterior border of the dry tray from the buccal frenum area of one side to the buccal frenum area of the opposite side. Flame the compound with a Hanau torch. Temper the compound by placing it briefly in a 140° Fahrenheit water bath. Reflect the cheek with a mouth mirror and rotate the tray into the patient's mouth. Seat the tray in the patient's mouth. The upper lip is gently manipulated outward, downward, and inward. When set, remove the tray, Repeat the procedure. The compound should be rounded with no void, be symmetrical in shape, and should not be glossy. If voids are present or compound is glossy, add more compound, flame, temper, and repeat the procedure. Add compound to the right side of the tray from the previously molded area to the pterygomaxillary notch. Shape the compound with wet finger, flame, and temper it. Reflect the cheek with a mouth mirror and seat the tray. Grasp the cheek at the corner of the mouth and draw outward, downward, and inward. Also, manipulate the tissues forward and backward over the buccal frenum area. Remove the tray, reheat the compound, and repeat the process a second time. Repeat the same steps on the left side. Now, add green stick compound to the tissue surface of the posterior border of the final impression tray. The compound should be approximately 4 mm wide and 2 mm thick. Flame, temper, and seat in the patient's mouth. Be sure the compound is soft in the areas of the pterygomaxillary notch and palate. Upon completion of the posterior border, the tray should exhibit good retention and stability. Note, if the border molded final impression does not exhibit stability and retention at this time, the complete denture will not be stable or retentive. You must determine the cause and make correction before proceeding to the next step. Remove excess compound on the labial and buccal areas to avoid excess bulk, which will disturb the shape of the vestibule. Dry the tray. If rubber base impression material is to be used, paint the tissue surface and the borders of the tray with an adhesive. Soften one end of the green stick compound slowly over the alcohol torch. Add compound to the border of the tray from the right buccal frenum to the right retromolar pad. Flame and temper. Reflect the cheek with the mouth mirror and seat the tray. Grasp the cheek at the corner of the mouth and draw outward and upward. Massage inward, forward, and backward. Remove the tray, chill it in ice water, and inspect. Do not remove excessive compound that has flowed into the tray. This will be done later. Soften one end of the green stick compound slowly the alcohol torch and place the compound along the anterior border of the dry tray from the buccal frenum of one side to the buccal frenum of the opposite side. Flame, temper the compound by placing it briefly in a 140-degree Fahrenheit water bath. Reflect the cheek with a mouth mirror and rotate the tray into the patient's mouth. Position the tray and seat it in the patient's mouth. Draw the lower lip gently outward, upward, and inward. When set, remove the tray, examine the border, and chill in ice water. Place green stick compound on the right distolingual border from the end of the border molded area to the right retromolar pad. Shape with wet fingers. Flame. Temper and seat. Ask the patient to place the tongue tip back and up as far back as possible. Next, have the patient protrude the tongue and place the tip in the left corner of the mouth. Remove the tray, inspect it, and chill it in ice water. Upon completion of the sublingual crescent border, the border molded tray should be stable during tongue movement and manipulation of the border tissues. Evaluate the stability of the border molded mandibular tray with the tongue at rest. Remove excess compound from the interior of the tray. Also remove any compound covering the retromolar pads. Remove excess compound from the labial, buccal, and lingual surfaces. Dry the tray. Paint the tissue surface and borders of the tray with rubber base adhesive. Dry the palate and basal C tissue with gauze. Have the patient close and retain the gauze in the mouth. Remember, over-drying the mouth will stimulate salivary flow. If using rubber base impression material, place equal 4-inch length of light body base and catalyst on the mixing pad. Place Vaseline over and around the patient's mouth and lips. Mix until homogeneous. Distribute the material uniformly in the tray using a small cement spatula. Over the borders 2 to 3 mm into the labial and buccal surface of the tray. Place only enough impression material in the posterior of the tray to record the tissues. Excess material will flow out of the posterior of the tray and cause the patient to gag. Remove the gauze from the patient's mouth. Standing to the right of the patient, rotate the tray into the patient's mouth. Place the index finger on the posterior rim and fully seat the tray. The vestibular tissue may be briefly and lightly border molded for about 30 seconds after the tray has been seated. Retain the tray in position with finger pressure at all times. Allow the material to set. Generally, this is 3 to 4 minutes for fast set rubber base and 7 to 8 minutes for regular set rubber base. Remove the maxillary final impression. Inspect the impression to determine if it's acceptable. Disinfect the impression by rinsing excess saliva with water. Place the impression in a Ziploc bag and spray it with the current approved disinfectant. Wait 10 minutes before unsealing bag and pouring the impression. Checklist for maxillary final impression. Labial and buccal vestibular reflection are fully recorded. Pterygomaxillary notch is recorded. Palate and vibrating line recorded without voids or distortion. No tray showing through the impression material. Labial and buccal freni recorded. Uniform color or impression material indicating proper mixing. No large voids or wrinkles in the impression surface. Place equal 4-inch length of light body rubber base catalyst and base on the mixing pad. Mix until homogeneous. Distribute the material uniformly in the tray using a small cement spatula. Cover the borders 2 to 3 mm onto the labial and buccal surface of the tray. Remove the gauze from the patient's mouth. Standing to the right of and in front of the patient, reflect the patient's cheek with a mouth mirror and rotate the tray into the patient's mouth. Instruct the patient to open his or her mouth widely and lightly protrude the tongue and lick the upper lip from one corner to the other. Hold it in position with the index and forefinger with enough pressure to keep the tray seated. The vestibular tissues may be briefly and lightly border molded for about 30 seconds after the tray has been seated. Allow the material to set. Remove the final impression. Inspect the impression to determine if it's acceptable. Checklist for the mandibular final impression. The labial and buccal borders are fully recorded. Retromolar pad covered. Retromylohyoid area covered. No tray showing through the impression material. Lingual, labial, and buccal freni correctly recorded. Using a sharp scissor, trim the excess impression material. Remove any unsupported impression material which would distort when the impression is poured, especially in the lingual flange area. Paint the borders of the tray with elastomeric impression material adhesive and wait until it's set. Place heavy body elastomeric impression material along the periphery of the tray. Place the tray in the patient's mouth and instruct him to perform movements such as sucking a finger or pursing the lips. The vestibular tissues may be briefly and lightly border molded for about 30 seconds after the tray has been seated. Retain the tray in position with finger pressure at all times. Allow the material to sit according to the manufacturer recommendations. Remove the maxillary final impression tray. Inspect the impression to determine if it's acceptable. Remove all excess material from the tissue surface of the tray using sharp knife. Paint the tray with polyether adhesive. The final impression is completed with light body polyether impression material. Follow the same steps as for rubber-based impression material. Place a ball of Play-Doh on a flat surface. Create a concavity in the Play-Doh to accommodate the final impression. Place the final impression into this concavity. Try to seal around the impression using wet finger. About 2 to 3 mm of the impression borders should be visible, superior to the Play-Doh, and all the tissue surface should be Play-Doh free. Again, use wet finger to smoothen and seal the surface of the Play-Doh. Wrap a strip of boxing wax around the Play-Doh. Seal it with hot wax spatula. The advantages of using this technique are its speed and ease of use. Block out severe undercuts on the maxillary cast with hard base plate wax. If the ridge is very thin, flow wax on each side to prevent fracturing the cast. Excessive block out will decrease the retention of the record base. Remember, your goal is to protect the master cast. Lubricate the ridge and land areas with Vaseline. Remove any gross excess. Adapt a sheet of pink triad base plate material to the maxillary cast starting in the palate and proceed to the borders to prevent trapping air in the palate. Trim the triad to the depth of the vestibule labially and buccally and to the most posterior extent of the impression. Take care not to create a thickness of less than 2 mm. Shape the material prior to curing, as it is much easier to smooth it when uncured. Cure the record base for 4 minutes in the triad unit. Carefully remove from the cast. Invert and cure the tissue surface for 4 minutes. You must cure the record base a total of at least 8 minutes for the triad material to become fully cured. Breaking can result if not fully cured. Smooth and trim the borders of the record base until completely smooth. Block out severe undercuts on the mandibular cast with hard base plate wax. If the ridge is very thin, flow wax on each side to prevent fracturing the cast. Excessive block out will decrease the retention of the record base. Lubricate the ridge and the land areas with Vaseline. Remove any gross excess. Cut a V-shaped wedge out of the middle of the triad sheet to permit adaptation of the wafer to the lingual of the cast. Adapt the material as before and cure. Follow the same instructions as for the maxillary tray. The procedure for the mandibular record base is identical to the maxillary. Dry the record base thoroughly as wax will not adhere to a wet surface. Roughen the area of the record base where the wax will be adapted. Soften one end of the sticky wax slowly over a Bunsen burner flame. Place the sticky wax over the ridge crest area of the record base. Uniformly soften a sheet of hard pink baseplate wax. Flame the wax in a Bunsen burner flame slowly by passing the wax quickly through the flame many times. When the wax is thoroughly softened, fold the wax. Continue to flame the wax to soften it. Repeat the folding and warming until the entire sheet of wax is used. Form the wax into a horseshoe shape and adapt the wax to the record base. Seal it to the record base with a molten wax using a hot spatula. Add wax as needed to contour the rim. The rim should approximate the position of the natural teeth. Remember, the facial surfaces of the central incisors are 5 to 9 mm anterior to the center of the incisive papilla. Use a pancake turner or a heated wax spatula to develop a flat occlusal plane. The width of the occlusion rim in the molar area is 8 to 10 mm, 5 to 7 mm in the premolar region, and 3 to 5 mm in the anterior. The facial surface of the wax rim is approximately 5 to 9 mm anterior to the center of the depression of the incisive papilla. The posterior vertical height measuring from the basal seat surface of the tuberosity to the occlusal plane is 8 to 10 mm. Anteriorly, the rim is positioned slightly labial to the residual ridge. The rim will measure 22 mm from the anterior labial border to the incisal edge. The rim must be clean, neat, and of proper dimensions and contour. The procedure for making the mandibular rim is very similar to that of the maxillary rim. Dry the record base thoroughly as wax will not adhere to a wet surface. Roughen the area of the record base where the wax will be adapted. Soften one end of the sticky wax slowly over a Bunsen burner flame. Place the sticky wax over the ridge crest area of the record base. Uniformly soften a sheet of hard pink base plate wax. Flame the wax in a Bunsen burner flame slowly by passing the wax quickly through the flame many times. When the wax is thoroughly softened, fold the wax. Continue to flame the wax to soften it. Repeat the folding and warming until the entire sheet of wax is used. Form the wax into a horseshoe shape and adapt the wax to the record base. Make the height of the rim about 15 to 18 mm from the anterior border to the incisal edge. The shape, position, and dimension of the rim should represent those of the natural teeth. Posteriorly, the occlusal surface gradually widens in width from 3 to 5 mm in the anterior region to 8 to 10 mm in the molar region. Posteriorly, the wax rim parallels to the base of the cast, the residual ridge, on a plane intersecting the retromolar pad at 2/3 of the pad's height. Note that the rim's occlusal surface ends at the distal of the first molar and is beveled posteriorly and inferiorly from this point. Gently dry the tissues in the posterior palatal seal area and pterygomaxillary notch with a gauze sponge. Locate the pterygomaxillary hamular notches. Mark the notches with an indelible marker. Locate the vibrating line by having the patient say a series of short ahs, and mark it in the mouth with an indelible marker. Mark the area of the soft palate where movement just begins. Insert the dried maxillary custom tray into the patient's mouth and fully seat it. Remove the maxillary custom tray. The indelible marker may have transferred to the custom tray. If the line has not transferred to the custom tray, reinsert the tray and instruct the patient to blow through his nose while you gently pinch it shut. Look in the patient's mouth. You may be able to see the indelible marker line through the translucent tray. Trim the posterior border of the tray to the transferred line using a burr designed for trimming acrylic. Reinsert the tray in the patient's mouth and evaluate the relationship to the posterior border of the vibrating line. Adjust until the correct length is obtained. Note that the fovea palatini are not reliable indicators of the location of the vibrating line. Place the maxillary record base in the patient's mouth. Observes the patient's upper lip. Approximately 1 to 2 mm of the wax should be visible in the average patient. Some patients may not show any wax at rest because they have long upper lip. Determine the relationship of the planes of the wax rim to the interpupillary line and the ala tragus planes using the Fox occlusal plane indicator and a tongue blade or 2 tongue blades. Remove the maxillary record base and occlusion rim from the patient's mouth. Adjust the occlusion rim to be parallel to the interpupillary and ala tragus planes by adding or subtracting wax from the occlusion rim. A heated rubber-based spatula or pancake turner works well for this. Drip excess wax on a folded paper towel and discard to keep your work area neat. Reinsert the base in the patient mouth and recheck the occlusal plane with the landmarks. Repeat the procedure until a satisfactory plane of occlusion is established. Scribe the midline on the maxillary limb at this time to represent the location of the central incisors. Next, scribe the high lip line perpendicular to the midline as the patient smiles. Scribe the right and left canine lines at the corners of the mouth when at rest. Make two V-shaped grooves on the right side of the maxillary occlusal rim, one in the premolar area and one in the molar area. These grooves should not be more than 2 mm in depth. Repeat on the left side of the maxillary occlusion rim. Place the maxillary record base in the patient's mouth. Place a small amount of bite registration material on the Facebow fork, then place it in the patient's mouth. Wait until the registration material is set, then ask the patient to hold the maxillary record base in place with his or her fingers. Assemble the Facebow apparatus following the manufacturer instructions and make the Facebow transfer record. Note: always explain to the patient that you are going to use a caliper-like device for the procedure and that you will need his or her assistance. Assure the patient that he or she will undergo no discomfort, but will feel a little pressure. Tell the patient that it will only take a few minutes to complete the procedure. Place the mandibular record base in the patient mouth and evaluate the position of the occlusal plane and do all necessary adjustment for the mandibular wax rim. Then check both maxillary and mandibular wax rims in the patient mouth. Mark a small dot on the nose and the chin to serve as reference points. Ask the patient to say "Emma" several times and relax his jaw, or swallow and relax his jaw several times. Use a tongue depressor blade to record the distance between the reference points when the patient jaws are in the physiologic rest position. This measurement on the tongue blade is the vertical dimension of rest. It should be relatively constant after several repetitions. Only maxillary record base and occlusion rim inserted to provide lip support. Mark the tongue depressor blade 3 mm short of the vertical relation of rest. This is the vertical relation of occlusion for most patients. The occlusion rim is adjusted by trimming the wax rim with a heated spatula or knife. Replace the record base in the patient mouth and verify using the tongue blade that you have established the vertical dimension of occlusion you desire. Practice guiding your patient into centric relation with the record bases in the patient's mouth. You must hold the mandibular record base in position with your hands when making a centric relation record for complete denture patients, as the mandibular record base can lift away from the patient tissues, invalidating your records. Remove a strip of posterior occlusion rim approximately 1 mm in depth from the mandibular occlusion rim on both sides posterior to the canine lines. Place the occlusion rims in the patient mouth and verify that both rims occlude evenly on closing. Adjust the rims if they do not. Close the patient into centric relation. Bite registration paste or aloe wax can be used as a recording medium. Place a small amount of the material on the mandibular occlusion rim in the area of the premolars and molars. Carefully place the record base in the patient's mouth and slowly guide the patient into centric relation. Hold the mandibular record base in position with your index fingers when guiding the patient into centric relation. Wait for the material to set according to the manufacturer recommendations. Always hold the record in place yourself. After the recording medium has set, remove the record base from the patient's mouth and inspect it. There should be no contact between the acrylic bases, wax rims, or master casts. Return the record to the mouth and check it for repeatability. This record must be repeatable. After you have completed your centric relation recording, you are ready to mount the maxillary and mandibular master cast. Check the size, form, shade, and arrangements of the teeth on the articulator. Harmony and pleasing natural appearance are the goals. Place the maxillary trial denture base and check for midline, occlusal plane, and stability. At this time, do not forget to check vertical dimension and occlusion and do all necessary adjustment at this stage. When the functional and aesthetic factors are correct, phonetics seldom presents a problem. It is helpful to attempt to engage the patient in a meaningful conversation in which the patient expresses himself or herself in a natural way. During the conversation, certain sounds should be observed carefully, the F, V, S, and TH sounds. Remember, all patients will have some difficulty with new dentures and require an adaptation period. Do not be too demanding of phonetics at this stage. Use your fingers to feel any sharp projections, blips, or rough areas that would injure the patient and remove it. Remove the BIP paste from the jar with the tongue blade to avoid contaminating the entire jar with the brush. Paint a layer of the paste over the entire tissue surface of both dentures using the brush provided. Place the dentures in the patient's mouth. Have the patient close on 2 cotton rolls, one on the right side and one on the left, for 2 minutes. Remove the dentures from the patient's mouth. Observe the areas on the tissue surface of the denture where the paste has been displaced by heavy contact with the tissue. Relieve these areas. Reapply the paste until the denture contact the tissue surface evenly. Remove the pressure indicating paste using gauze when all tissue adjustment have been completed. After you have adjusted the tissue surface of the dentures so they are comfortable to the patient, your next procedure is the clinical remount and occlusal refinements. Use a rigid recording material, aloe wax, to make a centric relation record. Place the recording material on the patient's mandibular denture and carefully make the new CR record. Gently guide the patient into centric relation. When the recording material is set, remove the denture. Mount the mandibular remount cast using the mandibular denture and the new centric relation record. Adjust the occlusion using selective grinding principles. Be cautious of maintaining the established vertical dimension of occlusion.